Hi, and welcome to the brand new and very first episode of the IJA podcast. I'm Dr. Gayatri, and joining me here is Dr. Rashmi, and together we bring you the year end issue of the Indian Journal of Anaesthesia. So, without wasting another minute, let's catch up with a man with a mission, the editor in chief of the Indian Journal of Anaesthesia, Dr. Rakesh Garg. Dr.
Thank
Rakesh,
you, Dr.
hi, it's a pleasure to have you join us.
Thank you, Gayatri. Thank you so much for taking this podcast forward.
So I must first congratulate you for the brilliant work you have done for the journal so far. I know that the infographics especially have become extremely popular ever since their release in April. They're not only so visually attractive, but have also optimized readability. I also see that the impact factor of the journal is now 2.9, which is so commendable.
I think credit goes to the whole editorial board team. They are working so hard to bring this journal to this big platform. Credit also goes to all the ISA members, the governing council, and the leadership who is supporting the IJA to the large extent. And special thanks to all our reviewers and authors. Actually, the credit goes to them because their work, their dedication, their hard work in the form of a research is bringing the IJA to such a large extent, to such a big platform.
Absolutely. So, can I ask you to quickly tell our listeners what exciting new things are in store for them in the current issue of the journal?
Absolutely. I think December issue of 2023 of Indian Journal of Anaesthesia is bringing enormously great contribution to the academics. It has many systematic reviews and meta-analysis. And we know that meta-analysis has the highest hierarchy of evidence. And so we bring almost 4 systematic reviews and meta-analysis in this issue. And I'm sure they are going to benefit all the leadership to improve their patient care outcome and patient, it will have a lot of clinical translational value. And added to it, we'll have original articles and letters also, which are again provide a lot of insight into our clinical practice. So I think I'm sure December issue will be of the IJA will definitely be very informative to all the readers.
Yeah, it looks like a very good mix of work out there. So can I ask you, as chief editor, which articles in this issue, according to you, were eye catchers?
I think this is absolutely a difficult question for me because as an editor-chief, I have seen that all the articles are absolutely very, very important. All the articles are absolutely brilliant from the academic point of view. But just to emphasize, I think I was really impressed to see a couple of them. By article by Dr. Sonal Goyal et al., Efficacy of Splanchnic nerve neurolysis in the management of upper abdominal cancer pain, a systematic review and meta-analysis. Another article by Dr. Raghu S. Thota et al., a systematic review and quantitative analysis of the cancer pain guidelines. Many original articles, but I think Dr. Medha Motas et al., the article of the effect of timing of intraoperative administration of paracetamol on post-operative sharing, a randomized double-blind controlled trial, they are eye-catching, and I'm sure that they will be really influential for some clinical translational role in our patient care.
And so it's interesting that we have 3 articles that caught the eye of the editor-in-chief. So let's see if Rashmi has managed to get hold of the authors of these articles, and let us find out from them what went behind the scenes of their work.
Hello, everyone. This is Dr. Rashmi. Let us discuss some important tips and notes about our first article today. That is about the effect of timing of intraoperative administration of paracetamol on post-operative shivering. For this, I would like to welcome Dr. Medha Mehta, who is a professor in the Department of Anesthesiology and Critical Care at University College of Medical Sciences and Bahadur Hospital, Delhi.
Thank you, Dr. Rashmi.
Ma'am, your first question is, what was the idea behind conducting the study and what were the objectives?
Okay, so post-operative shivering after GA is a very common problem. A number of drugs have been tried to reduce its incidence, and recently paracetamol or PCM has also been tried for this purpose. So we all know that IV PCM is quite effective and safe for managing fever and mild to moderate pain. Nowadays, it is actually being used routinely as part of multimodal analgesia during GA. But what about its anti-shivering effect? What happens in the post-operative period, there is an increase in the core body temperature set point, and shivering occurs to achieve this set point. PCM acts through centrally mediated prostaglandin inhibition and decreases this hypothalamic set point, thus having an anti-shivering effect. But at the same time, we must also understand that PCM has been shown to reduce body temperature even in the absence of fever. So, it may also exacerbate perioperative hypothermia in patients whose body temperature is not strictly maintained in the normal range. So, although PCM has an anti-shivering effect, it may reduce its own efficacy by causing perioperative hypothermia when administered before surgery. So, this study tried to compare the effect of different timings of IV PCM administration. Our primary objective was to study the incidence of post-operative shivering, whereas the secondary objectives were to compare the incidence of perioperative hypothermia, time to analgesic requirement, and any post-operative complications.
Right, doctor. Could you please tell us how did you measure the incidence of hypothermia and shivering?
Okay, the patient's core temperature was monitored using an infrared tympanic membrane thermometer before induction, after induction, every 15 minutes intraoperatively before reversal, and every 30 minutes in the recovery room for 4 hours. Intraoperatively, all the patients were covered with forced air warmer, and in the post-operative period, they were covered with a single blanket. So body temperature below 36 degrees centigrade was considered as hypothermia. Shivering was assessed according to a scale used by Cowley et al., where it was graded from 0 to 4. And grades 3 and 4 shivering episodes were treated with IV tramadol 1 mg per kg.
Doctor, why do you think the incidence of shivering and post-operative hypothermia was lower when paracetamol was administered late before the completion of the surgery?
Okay, so before answering this question, let me just tell you what our results were. We had actually divided our patients into 3 groups. We had studied 225 ASA 1 and 2 patients, and surgical procedures performed under GA with expected duration between 1 and 4 hours were chosen. And the patients were divided into 3 groups of 75 patients each: early PCM group, late PCM group, and control group. Now, in early PCM group, the patients received IV PCM 15 mg per kg up to a maximum of 1 gram over 15 minutes immediately after induction of anesthesia. Whereas in late PCM group, the same dose of PCM was administered approximately 30 minutes before completion of surgery. The control group received only normal saline and no PCM. So in this study, we found that the overall incidence of shivering and the shivering requiring treatment was lower in the late PCM group than in the other 2 groups. The other 2 groups, that is early PCM and control groups, did not show any statistically significant difference between the 2. Now, the incidence of post-operative hypothermia was also significantly lower, and the time to rescue analgesic was longer in the late PCM group. So now I'll come to your question that why the incidence of shivering and post-op hypothermia was lower in the late PCM group. See, the onset of anti-shivering action of PCM is almost similar to that of its analgesic action, whereas the peak hypothermic action occurs at about 120 minutes. Thus, when PCM was administered early, that is immediately after induction, its anti-shivering effect must have been there. But at the same time, its hypothermic action, along with anesthesia-induced hypothermia and other factors like OT temperature or surgery-related factors. So all these factors would have combined and resulted in hypothermia and thus shivering in a large number of patients. Whereas in the late PCM group, the analgesic and anti-shivering actions came into effect without significant hypothermic effect and hence reduced the incidence of hypothermia and shivering.
Doctor, what do you think is the conclusion of this study?
Okay, so in this study, the administration of IV PCM 30 minutes before completion of surgery resulted in a lower incidence of post-operative shivering and hypothermia and provided a better analgesic effect than the administration of PCM after induction of anesthesia or no PCM. And all of us routinely give PCM to our patients. But according to the results of this study, I think it would be better to administer PCM towards the end of surgery to have the best possible results. So that is the main conclusion of our study.
Right. Thank you, doctor, for this very descriptive information.
Thank you, Rashmi.
Thank you, Rashmi.
So the next
next
article that we're discussing is a systematic review and quality analysis of cancer pain guidelines by Dr. Raghu S. Thota et al. And for discussing that, we have the very effervescent Dr. Raghu Sudarshan Thota, who is professor in the Department of Palliative Medicine, Tata Memorial Hospital. Dr. Thota, thank you so much for joining us.
Thank you.
So I want to ask you first, Dr. Thota, what was your thought process when you decided to do this review and quality evaluation of cancer pain guidelines? Or why did you feel there was a need to review these guidelines?
Own countries, Indian cancer pain guidelines. So this thought process had come that there are many guidelines which are available for the practicing pain physicians, but they are confused about which one to be used because of there is a varied non-uniformity of these guidelines based on I can say the resources available in that particular country or institutional restrictions. So that's why the practitioners are very confused of what exactly to do, which guidelines to which we need to use. So that was the main thought which had come when we were writing about own guidelines, and we thought, why not we review all the guidelines and come to a point of uniformity or universality.
So you're basically looking for guidelines that could be globally adaptable, right?
Yeah.
So what were the qualities you were specifically looking for while reviewing these guidelines?
So there are many ways we can assess guidelines, but what we have used is something called as an agree-to score. So which basically classifies and dissects the guidelines into particular 6 domains. So the domains are like the rigor of development or the clinical evidences which they had used, applicability, editorial independence, and at all. So there are so many things, of which the most important is the rigor of development. So how they are developed, whether they have used the systematic methods like Prisma and all these things. So we have looked into those things and we have scored this guideline. So we had given this to two independent reviewers who are practicing cancer pain for the past 15 years. So we had given to a senior level independent reviewers who had looked into this. They have scored it and they had given the certain scores, of which only 4 guidelines out of the 14 guidelines were highly rated.
Yeah, and I also saw that you in your initial search, you got about 28,700 articles, and that must have been such a laborious process.
Yeah, rigor of
yes.
So yeah, it's a
so
ultimately shortlisted to 14 guidelines based on various exclusion criteria, which we have enlightened.
Yes. All right. So then, according to your study, sir, which guidelines were found to be of the highest quality?
So this is a WHO guideline. Then there is an NCCN guidelines. Then there is something NCEC, NCG guideline. There is a Ministry of Health Malaysia guidelines. They were highly rated based on all the 6 domains, and particularly the rigor of development and the clinical evidence which they had used in their. And if you see, all these guidelines have imbibed, inherently used the safe practice of opioids, all the guidelines, all the 14 guidelines. But these 4 guidelines are highly rated guidelines.
Yeah, so these 4 guidelines, according to you, have the highest clinical impact when used, right?
Yes.
Yes. So thank you, Dr. Thota. Your article also, I must tell you, provided such an interesting insight to me into the development methods and quality evaluation process that a new guideline goes through. So I'm sure that our readers will also be fascinated by how guidelines are made. So thank you so much.
Thank you.
Thank you, Dr. Gayatri. Next, we have Dr. Sonal Goyal, who is specialized in pain management and focused in comprehensive patient assessment and interdisciplinary multimodal treatment approach. She is an assistant professor at MGM Medical College and Hospital, Mumbai. Her expertise in plexus block and neurolysis for cancer pain management is what has led her to publish this article about the same, that is the efficacy of splanchnic nerve neurolysis in the management of upper abdominal cancer plain. Dr. Sonal, can you please summarize the study for us?
Good evening, everyone. Thank you, Dr. Rashmi, for such a nice introduction. So, coming to this study, so this was a systematic review and meta-analysis which was planned to evaluate the efficacy of splanchnic nerve neurolysis for the management of cancer pain in patients suffering from upper intra-abdominal malignancy. The primary objective was to assess the analgesic efficacy, whereas the secondary objectives were to assess the effect of neurolysis on daily narcotic consumption, then on quality of life, then on patient survival, and the procedure related complications. So we systematically searched the databases like PubMed, Embase, Cochrane, and Scopus for the study published till October 2023, and total 14 full text articles were included in the final analysis. Overall, the splanchnic nerve neurolysis was found to be effective in reducing the pain, reducing the daily narcotic consumption, improving the quality of life, and the minimal complications was associated with the procedure.
Thank you, ma'am. Before I move ahead with the results and outcomes of the pain, I just wanted to know, according to you, what are the most frequently used neurolytic agents, ma'am?
So the commonly used neurolytic agents are alcohol and phenol. Clinically, alcohol is most commonly used in concentration of around 50%, whereas in phenol, the most commonly used concentration is around 6.7%. More or less, the mechanism of both the neurolytic agents are same. It is mainly protein coagulation and non-segmental demyelination involving the neural tissue. But despite of alcohol being associated with higher complication rate, it is not advisable to use phenol in cases of celiac plexus block due to its inherent nature of ischemic effect, and it has high sensitivity for the vascular complications.
Thank you, ma'am. Just in quick word about the results of the study, ma'am.
So the main primary objective was the pain outcome, and the significant reduction in pain score was seen at all the follow-up time points over the 6 months of follow-up. But again, the outcome was limited due to the shortcomings of the included studies. The substantial amount of heterogeneity was observed in the included study, which is mainly due to the clinical and methodological parameters. The clinical heterogeneity is mainly due to the differences in the population characteristic, then disease severity and the treatment response, whereas the methodological differences are due to the variations in study design, then sample size, then follow-up duration, then the outcome parameters and the data collection method. So despite of getting the positive outcome, the evidence which we have obtained in this analysis was not that the evidence was of low quality, considering the substantial heterogeneity which we have observed in this study.
Thank you, doctor, for this very important insight. This is the end of our first podcast. Thank you all for your patient hearing, and hope most of your uncertainty and doubts about a few articles were answered here. We are hoping to come up with new articles and newer facts and figures for the upcoming year 2024. Wishing you all a Merry Christmas and a happy, prosperous New Year. Thank you.